Three findings, that is irregular hypoechoic lesion taller than wide appearance, presence of irregular solid component in cystic lesion. Like that, here also you remember just three findings. Here once again irregular, but irregular lesion with spiculated margin, and this calcifications, pleomorphic microcalcifications. Some scattered calcifications or macro calcifications or popcorn calcification, they are not malignant finding. This is the one, pleomorphic microcalcifications, and like that it's architectural distortion. There will be a distortion in the architecture. These three findings, it can be a malignancy in mammogram. Okay, this one I already told. Worldwide, this mammogram is used as a screening tool. Ultrasonogram is not as a screening tool, but mammogram is used for screening. So for screening, when you are reporting, there should be a standardized format. ஒரு இன்ஸ்டிடியூட்ல இப்படியே இன்னொரு இன்ஸ்டிடியூட்ல இப்படியே ரிப்போர்ட் பண்ணா உன்னால என்ன பண்ண முடியாது, கோரிலேட் பண்ண முடியாது. So there should be a uniform reporting throughout the world. So for that we are following this breast imaging reporting and data system for American College of Radiology. So what is BIRATS 0? அதுல வந்து பாத்தீங்கன்னா the picture is not clear, some other thing needs further evaluation. So forget that. What is 1? Mammogram taken, it's good quality, no finding, normal. So mammogram taken, good quality, no finding, it's negative. Negative means there is no lesion in mammogram. So 2, it is a benign finding. The mammogram is clear, there is a lesion, but there is no finding to suggest malignancy, it is benign. Now starts 3. They will tell the scoring is BIRATS 3. So BIRATS 3 is, it's not benign, it's not malignancy, probably benign. That is more towards benignity. Remember, in a BIRATS 3 lesion, the possibility of malignancy is up to 2%. Up to 2%. So there they will suggest that the patient needs close follow-up like that. BIRATS 4. So most of the time we used to get BIRATS 4 type of lesions. So in BIRATS 4, it is a suspicious abnormality. So here it goes towards malignancy. So BIRATS 4, suspicious abnormality. Even now, remember, here the possibility of malignancy is above 2% and up to 95%. It is a vast category. BIRATS 4. Then comes your BIRATS 5. It is highly suggestive of malignancy. Highly suggestive of malignancy. The possibility of malignancy is almost more than 95%. So these 5, from negative to positive. Negative, benign, probably benign, suspicious, suggestive. The last one is, we have already told that it is done for proven malignancy. Already proven, now we are taking mammograms. Because previously they have not taken mammogram, patient is coming with a positive diagnosis. Now we are taking mammogram to suggest the proper definitive treatment. So I already told, anything has a balance. Mammogram. So advantage is, it's a effective screening method. Definitely it's a very effective screening method. Microcalcification is well delineated. Because most of the time, if the patient is having a non-palpable lesion, if you take mammogram, it will detect this pleomorphic microcalcification, so we can detect malignancy earlier. But what is the disadvantage? The picture, you saw the picture, pain during compression. And it's somewhat difficult in small breast. And pregnancy, since it is a X-ray, it is a low voltage, high amperage X-ray, and in pregnancy it's not recommended. Then remember these investigations, I am repeatedly telling, these are only for indicated patients. They are not taken as a routine. So MR mammogram, MRI. The first point I want to stress, MRI will not demonstrate microcalcification. Remember, these microcalcifications cannot be picked up by MRI. And it is not always recommended as a routine. Some useful situations where MRI is useful to your routine investigations. That is women with implants. And sometimes to distinguish scar from recurrence, it will be useful. very high risk young women, MRI is used as a screening modality. And in pregnant women, remember for taking MR mammogram, most of the time that MRI machine should have a dedicated breast coil, and most of the time MR mammogram will be done with contrast. But pregnant woman, you are having some indeterminate USG finding, then you can take MRI but without contrast. And in post, nowadays the breast conserving protocol is increasingly accepted by patient. So for that patient also, to find out the difference between some scar and recurrence, this MRI may be useful. So I routinely omitted PET scan. I will come to PET scan in the last slide. So you have completed clinical examination and imaging. You have come to a provisional diagnosis. Your provisional diagnosis is ready. So you want to confirm your provisional diagnosis. So pathology. Now comes pathology. So in pathology, two investigations are available. One is FNAC and core needle biopsy. See, remember, it is preferred to do biopsy after all radiological investigations. And biopsy is the only reliable method. Remember, even though clinically, even though radiologically, if the lesion mimics malignancy, never say that patient உங்களுக்கு கேன்சர் இருக்கு அப்படின்லாம் சொல்லக்கூடாது. டவுட்டா இருக்கு, நம்ம பயாப்சி எடுத்து உறுதிப்படுத்திட்டு தான் சொல்லுவோம் அப்படின்னு. நீங்க பாட்டில் என்ன பண்ணிடக்கூடாது, போற போக்குல உங்களுக்கு கேன்சர் இருக்குன்னு சொல்லிடக்கூடாது. இட்ஸ் a huge diagnosis, remember. So biopsy is the only reliable method to determine presence or absence of malignancy. And the one thing is, needle biopsy is not going to disseminate the tumor. இப்போ கூட ஒரு 1 month முன்னாடி ஒரு மெடிக்கல் ஆஃபீஸர் வந்து என்கிட்ட வந்து அவங்க ரிலேட்டிவ்க்கு சார் பயாப்சி பண்ணா ஸ்ப்ரெட் ஆகுமா அப்படின்னு கேட்டாரு, மெடிக்கல் ஆஃபீஸர். ஸோ அதனால தான் சொல்றேன், needle biopsy is not going to disseminate the tumor. Okay, biopsy. One is FNAC and other one is core needle biopsy. The core needle biopsy நீங்க true cut biopsy சொல்றீங்களா, அதான் core needle biopsy. Core needle biopsy என்ன, a core of tissue, a core of or some cores of tissue are taken for biopsy. So FNAC, as you know, it's very simple. Within a few hours you can get the report. And it is the cytological diagnosis. You cannot differentiate in situ lesion from invasive lesion. Then what is the role of FNAC? The thing is, suppose if the patient is having axillary nodal involvement, supraclavicular nodal involvement, in that case FNAC positivity is very useful. And core needle biopsy, definitely it is a histopathological examination. Any pathologist can interpret with confidence, and you can do immunohistochemistry for your receptor status, that is estrogen receptor, progesterone receptor, HER2 and tumor proliferation at Ca.67. So these are the two things. By core needle biopsy, most of the time you will be able to get a histopathological diagnosis. In that also, remember, if the core needle biopsy is inconclusive, then I will come in the another slide. Suppose core needle biopsy not possible, then what you can do is you can go for a open biopsy. So open biopsy, if it is a huge lesion, just do a incision biopsy. If it is a very small lesion, you can do a excision biopsy. But remember, during excision biopsy, you orient the incision properly, so that if the lesion is coming as malignancy, when you are doing a definitive surgery, that incision has to be taken along with the tumor. So remember, before starting neoadjuvant chemotherapy, this histopathology documentation is a must, and receptor status has to be done before starting neoadjuvant chemotherapy, because sometimes after giving neoadjuvant chemotherapy there is a possibility of complete response. And remember, there is a possibility of false positive and false negative report in FNAC. So all are over. This CIP, you have given CIP, clinical, imaging and pathology, everything is over. So now you interpret. All the reports are on your table. The patient has come to you, you have done CIP, all the reports are on your table. It is you to interpret. You have to interpret carefully. The positive predictive value is 99.9%. நம்ம எப்போதுமே 100% சொல்ல முடியாது. அதனால the positive predictive value of this CIP is 99.9%. And if there is a discordance, there should be concordance. Remember, there should be concordance between clinical, imaging and pathology. Then only you can take the diagnosis as a full proof. If there is a discordance, say for example, clinically you are in strong opinion of malignancy, but the pathological report is not correlating. Suppose the pathology they have given us a malignant tumor, but clinically you are not correlating. Then you re-evaluate. You re-evaluate or put it in a multidisciplinary meeting, that is tumor board, before embarking upon definitive treatment. நிறைய டைம் வந்து பாசிட்டிவ் பயாப்சி ரிப்போர்ட் வந்து நாங்க திருப்பி எவாலுவேட் பண்ணி அது நெகட்டிவா இருந்திருக்கு. நிறைய டைம் நெகட்டிவ் பயாப்சி ரிப்போர்ட் வந்து திரும்ப எவாலுவேட் பண்ணி அது பாசிட்டிவா வந்திருக்கு. அதனால there should be concordance between all three, that is clinical, imaging and pathology. அதனால தான் போட்டிருக்கேன் in the background of suspicious clinical finding, ஒரு நார்மல் மேமோகிராம் does not rule out malignancy. இந்த false negative pathologist ரிப்போர்ட்ங்கிறது வந்து ரெண்டு விதமா வரலாம். ஒன்னு வந்து sampling error. Say for example, if you take biopsy from a necrosed area, the pathologist will report only as a necrosis. You have to take a representative biopsy, that is from the solid area, or a representative biopsy. In that case, if you are getting a negative core needle biopsy, still you are suspecting a malignancy, go for an image guided biopsy. Once again, you take a image guided true cut biopsy, like that. So sampling error should be avoided. So இது வந்து suppose you are having a malignant patient, so you have confirmed this is a confirmed case of malignancy. Other investigations, in the investigations வந்து not for diagnosis, this is for metastatic workup. நீங்க diagnosis க்கு வந்து you are doing ultrasonogram and mammogram, and now you are having a malignant patient, you want to do a definitive treatment. So before definitive treatment, you have to find out is there any metastasis, that is the metastatic workup. இந்த metastatic workupல for நம்ம நார்மலா CA breast வந்து operable breast cancer, locally advanced breast cancer, advanced breast cancer அப்படின்னு மூணு கேட்டகரி வச்சிருப்போம். For operable breast cancer, generally for guidelines there is no need for extensive metastatic evaluation because the chance of metastasis is less than 2% அப்படிங்கறாங்க. For a locally advanced breast cancer, there is a possibility of 20% chance for metastasis, so you have to go for a metastatic evaluation. So என்னென்னலாம் பண்ணலாம்? So clinical stage 1ல ஜெனரலா இதுல நான் USG abdomen போட்டுருக்கேன், அது கூட நீங்க எடுக்கணும் அவசியம் இல்லை. USG breast எடுப்பீங்க. நான் சொல்றது கைட்லைன்ஸ் படி ஜெனரலா for operable breast cancer there is no need for any extensive metastatic workup unless the patient is symptomatic. See, remember, stage 1, stage 2 patient, but if the patient is having suspicious findings, say for example you are taking a X-ray, chest X-ray, or if the patient is having some suspicious finding, or if the patient is having suspicious clinical finding for metastasis, never forget to take other investigations. Otherwise, totally asymptomatic, early stage, according to the guidelines, there is no need for any extensive metastatic workup. So stage 3, definitely possibility of metastasis is high. You have to take chest CT, abdomen, and PET CT is optional. PET CT is also optional. This slide. Nowadays, patient வரப்பே PET CT யோட தான் வர்றாங்க. இது வந்து ஒரு double edged sword கிட்டத்தட்ட. It's very useful, but we have to interpret very carefully. Because the sensitivity and the specificity of PET CT, it depends upon the size and histological type. Suppose very small size, the sensitivity comes down. Say for example, if the sub-centimeter tumor, say for example, if the size of the tumor is less than 1 centimeter, the possibility of detecting by PET is less than 50%. The patient க்கு tumor இருக்கும், ultrasonograph finding இருக்கும், but PET ல இருக்காது. So as the size comes down, the sensitivity of PET CT also comes down. And some type of malignancy in breast, say for example, நம்ம breastல வந்து என்ன சொல்லுவோம்னா tubular malignancy, it's a very good prognosis. And other pattern, lobular malignancy, that is lobular carcinoma. You remember invasive ductal carcinoma, invasive lobular carcinoma, the lobular carcinoma, and sometimes very well differentiated malignancy, the sensitivity, that is the FDG avidity will be somewhat less for a well differentiated malignancy, and in situ DCIS, ductal carcinoma in situ, lobular malignancy, and some favorable histopathology like tubular cancer, the avidity, that is the avidity of the fluorodeoxyglucose will be very low. And remember, this is sensitivity, FDG, and the PET-CT is not specific to malignancy alone. So PET-CT is not specific to malignancy alone. It can be positive in inflammatory as well as infectious disease. Many times tuberculosis node will be like a FDG avid node, and sometimes there is a possibility of upstaging the lesion. But for recurrent lesion, remember, for recurrence it is superior. Definitely it's superior. So PET-CT nowadays is useful in stage 3 and stage 4 and recurrent disease. At other stage, if the patient is having suspicious findings, clinical findings, you can take. Otherwise, routine PET-CT is not recommended as per guidelines. So I want to finish the carry home message. Clinical examination, the most forgotten thing. So proper history and clinical examination is the foundation for your diagnosis. அந்த ஃபவுண்டேஷனுக்கு மேலே தான் நீங்கள் இன்வெஸ்டிகேஷன்ஸோ பில்டிங்கையோ பில்ட் பண்ண முடியுமே வெளியே, ஃபவுண்டேஷனே இல்லாமல் நீங்கள் பில்ட் பண்ணீங்க அப்படின்னா அது என்ன ஆகிடும்? கீழே தான் விடும். ஸோ கிளினிக்கல் எக்ஸாமினேஷன் இஸ் த ஃபவுண்டேஷன் ஃபார் கரெக்ட் டயக்னோசிஸ். கன்கார்டன்ஸ், the triple assessment, clinical, imaging, pathology, there should be concordance, there should not be any discordance. If at all any discordance, never forget to put it in a multidisciplinary meeting or you re-evaluate carefully. And documentation of clinical finding is very important, and especially before starting neoadjuvant chemotherapy, you document the clinical finding, then only you send the patient for neoadjuvant chemotherapy. And the last one is PET-CT and MR mammogram are not routinely recommended as per guidelines. And thank you for giving this opportunity.
Thank you so much, sir, for the clear and practical overview on the approach to breast lump. We will continue with the discussion and the question session later. Now, continuing on this theme, we now have another distinguished speaker with us, Dr. Bala Mahendra, sir, consultant surgical oncologist from Apollo Specialty Hospitals, Madurai, who will be sharing his expert insights on the same topic.
Dr. Bala Mahendra, sir, a clinician known for his precision, dedication and compassion. He's a consultant surgical oncologist in Apollo Specialty Hospitals, Madurai.
Dr. Bala Mahendra, sir, has over 8 years of experience in cancer surgery and care. He trained at premier institutions including Maulana Azad Medical College and Tata Memorial Hospital, Mumbai, and earned his MCH in surgical oncology from Homi Bhabha Nation Institute.
He is a proud member of IMA, ASL and IASO, known for his patient-centered approach and commitment to excellence.
With great pleasure, we invite Dr. Bala Mahendra, sir, to share his insights on approach to breast lump.
I think Dr. Balu's slides are ready. I think you can ask any questions to Dr. Amuthan regarding the previous presentation. Please.
Exam going pages, you should be having a lot of doubts. Snithin, Anupama, Karan. Ask a few questions, keep the academic session going.
So, like, do you have final PGs here?
Yeah, they are exam going pages.
Right.
They are having exam another 10 days.
What is the staging workup that you do for your patients? Let us say there is a T to N0 patient. What staging workup do you advise for the patient?
Yes, answer. That's why I asked you to ask some question. Now he has started asking questions.
T2N0, what staging workup will you prescribe?
T2N0, we usually go.
No, I'm not asking the theory. What you do in your wards, that is what I'm asking.
So we go for chest X-ray,
Right.
then USG, abdomen and pelvis.
Okay, you don't ask for a PET at that point.
No, sir.
Right. What about
Don't usually
T3 and
recommend-
T3N1?
We,
Do you do in your everyday practice?
no, sir, no, we don't.
For what cases you ask for PET?
But stage 3 and 4 and metastatic cases.
Like, give me a clinical finding which will prompt you to send for a PET. Do you have if you have a supraclavicular node, will you ask for a PET?
Yes.
No. Do you do every day? I want to understand your practice pattern.
Yes,
Sir kept telling, like, too many PETs are being done, right? I want to emphasize that point. Do you ask for PET in an early stage, or do you only ask if there is a advanced stage?
if we suspect metastatic cancer.
Okay. How will you suspect metastatic?
Liver mets.
How will you suspect? After examining the patient, how will you suspect liver mets?
So with the if there is any support from USG, abdomen.
Okay. Your preliminary screening workup shows a metastasis, then you ask for a PET. That is what you are saying.
Yes.
Okay. Any other questions to Dr. Ramdas, sir? That was a very well structured presentation by Dr. Ramdas, sir. Because it was intended to clarify all the basic mistakes that we will make in our everyday practice. What we overdo, what we forget to do, all those points were elucidated very clearly in there.
Satish sir, I have a question for you. So, that's a clarification. So, now they say that FNAB can give us an idea about the receptor status.
Right.
So, still do we need to do a core needle biopsy?
I think Dr. Dean will be the right person to answer.